this morning we start with the unmet needs in Sjögren, a very important topic, I think. It was the topic of our campaign this year on World Sjögren's Day and the Awareness Month. And I love to introduce Chiara Baldini. She is a professor of rheumatology in the University of Pisa in Italy, and she is going to talk about the controversials in Sjögren. The floor is yours.
Good morning, everyone, and thank you so much for this kind invitation. It's beautiful to be here in these days. It's really amazing. So thank you so much for having me here. And thank you for this title that is Controversials in Sjögren. It's a challenging title, and I think that if I ask you which are the most controversial aspects in Sjögren, you may agree with me that one of the most controversial points is the discrepancy that we have between subjective symptoms and objective measures. There is this 6-9 situation in daily life that affects the diagnosis of Sjögren, the management of the disease, and the therapy. So I have subdivided my talk today in these 3 parts, and I really like to start by highlighting the importance that subjective symptoms have for the diagnosis of Sjögren. This is my unit, very close to the Leaning Tower in Pisa, and every Mondays, every Fridays, we have new patients coming with a suspect of Sjögren. And of course, the top symptoms are oral dryness, ocular dryness, pain, and fatigue. And we are all aware that these are the top symptoms for an early diagnosis of the disease. However, we also know that these symptoms are not so specific. In this slide, you can see the data collected regarding PROs out of around 300 of patients coming to our clinics in the last 3 years. And as you can see here, if you compare the scores assigned to the PROs by patients that at the end of the workup received the diagnosis of Sjögren versus the scores assigned by patients that at the end of the workup did not receive the diagnosis, things are pretty much the same. We do not observe any difference in the dryness, pain, fatigue, ESPRI, and this is why we need objective tests to confirm the diagnosis of Sjögren. However, things are a little bit complicated because we know that there is a moderate correlation between cyanometry and the oral dryness. We have a fair correlation between the ocular test and the ocular dryness, but we have a very low or absent correlation between symptoms, autoantibodies, biopsy, or salivary gland ultrasonography. So at the end of the workup, the diagnosis can be confirmed in the 50-60% of our patients. And therefore, the question here is why this discrepancy? And of course, we have a lot of diseases mimicking Sjögren. We have heard a lot about them yesterday, about drugs, infections, hormonal alterations that may mimic the disease. But considering particularly Sjögren, we have some important aspects to take into account. First of all, the dryness among the PROs is particularly related to glandular damage rather than to extraglandular disease activity, cytokines, or autoantibodies. The use of salivary gland ultrasonography has clearly allow us to understand this point. This is a paper by the Erika Boetsma group showing that patients with a high positive salivary gland ultrasonography indicating glandular damage are those patients complaining of the worst subjective symptoms and presenting the worst results in the objective test. So symptoms cannot reflect the extraglandular disease activity, but reflect more the glandular damage. But dryness does not result only from the glandular damage. There are other players not so strictly related to inflammation and cytokines. For example, an abnormal distribution in the aquaporin 5, as you can see here in the slides, that affects the formation of the water channels, thus impacting on the secretory function of our glands. And last but not least, we have comorbidities. We have talked a lot about comorbidities associated to Sjögren, ranging from thyroid inflammation, fibromyalgia, anxiety, depression, comorbidities that are particularly correlated with some specific PROs, including fibromyalgia, including pain, fatigue, and the overall ESPRI. Actually, things are even more complicated because when you want to have a border between Sjögren and comorbidities, you have to consider that Sjögren may contribute to some of these comorbidities. For example, a lot of research has been done on this pathway, the tryptophan-kynurenine pathways, and inflammatory cytokines may activate an enzyme, IDO, that catabolizes tryptophan to kynurenine, making tryptophan less available for the synthesis of melatonin, of serotonin, thus impacting on anxiety, on pain, on fatigue, and so on. So the first part of my talk actually pinpoints that this discrepancy can be somehow a point of weakness in our daily practice, to be improved through novel biomarkers, to align signs and symptoms, and to have a better and an earlier diagnosis for our patients. However, after this message that is not so not truly positive, actually this discrepancy can be a point of strength, not only a point of weakness when we go to the Sjögren management and to therapy, because we are well aware that Sjögren is actually a Janus bifronte with two phases. We know that we have the ESPRI, we have the SDI, we have the symptoms, we have the extraglandular activity. They are not correlated, but considering these phases of the disease as complementary, we can move towards clinical phenotyping, and we can end to this pie. In this pie, you can see that combining SDI and ESPRI, we can identify different phenotypes in Sjögren. We have that 1/3 of our patients have a well-controlled disease in terms of disease activity and PROs. We have that around 20% of our patients have a high extraglandular disease activity independently from the patient-reported outcome. But we have the slice that is the biggest, the largest slice, the gray slice, where the discrepancy between PROs and disease activity is the highest, where the controversial and the unmet needs are. Patients that are called population 2, those patients that have a high burden in terms of PROs and a low burden in terms of extraglandular disease manifestations. These patients are particularly challenging in the management because are those presenting the highest prevalence of comorbidities, including fibromyalgia. And those patients, in terms of therapy, are the real challenge that we are facing nowadays. Sorry. Okay. So these patients are the real challenge, I was saying, for the therapy today. We had in the 2020 the recommendations published. And for this population 2 patients with a high ESPRI, low SDI, the recommendations tell us that these patients are candidates to receive substitutes, saliva and artificial tears, but not DMARDs. But things in the present are changing because we have a lot of new insights into the pathogenesis of the disease, opening new avenues for novel biological agents targeting B cells, T cells, dendritic cells. So there is a lot, but the novelty, the true novelty is that all these new agents are possibilities for patients belonging to population 2. Patients belonging to population 2 can be eligible for these clinical trials. And I had the opportunity of participating to 3 clinical trials in which this specific population was included. And the necessity trial is ongoing. The iscalimab and the dazodalibep trial targeting the CD40 ligand pathway are, I think, critical points, critical steps towards targeted therapy in Sjögren. I particularly had the opportunity of presenting the results of the dazodalibep trial at 169 days. And as you can see here, the population that is controversial, the population that summarizes all the discrepancy between objective tests and PROs and subjective symptoms included in this trial actually met the first endpoint of the study with a significant change in the ESPRI and a significant changes in all the ESPRI domain subscales, dryness, fatigue, and pain. And this, I think, is our point of strength, to characterize better the patients, to take the discrepancy as a starting point for working together to a better control of the disease. So what's next? I've started showing you that symptoms are the keys for an early diagnosis of the disease, that the discrepancy between symptoms and signs is actually a point of strength for clinical phenotyping. And I want to conclude with this message that symptoms can be a therapeutic biomarkers. And the story of 2 of my patients, Christina and Carla, can tell us about this point. As you can see, both Christina and Carla belongs to population 2. They have the very similar profile in terms of objective tests, but they differ in symptoms. Christina can be defined as an high burden patient. Carla can be defined as a dominant dryness patient, according to the study that yesterday were presented by Fai and by Sarah McCoy as well in US. These patients have different genetic background, and they can respond differently to our drugs. The reanalysis of the Joker trials, TIRS trial, TRACTIS trials have opened new avenues in this perspective. So I like to conclude with some take-home messages. Sjögren, of course, is a disease so heterogeneous, so impacting on daily life that we have several unmet needs, but the discrepancy between PROs and objective tests can be our point of strength for clinical phenotyping and for looking at the symptoms as therapeutic biomarkers in the area of precision medicine. And thank you so much for your attention.
Thank you very much. I think the questions and answers are going to be at the end of the session.
Okay, and now is coming our Coralie to talk about the nomenclature, the discussion about what name we are given to Sjögren.
Okay, can I have the slides, please? Hello, everyone. Yeah. Thank you. So we decided to include that international nomenclature initiative in unmet needs. And I'll try to explain why. I'd like to acknowledge my colleague Cathy Amit from the Sjögren Foundation. Sjögren Europe was included in the international nomenclature on behalf of European patients, And Cathy, Amit, on behalf of American and the Sjögren Foundation. I will show you. Yeah. Okay, so the nomenclature survey was created to assess and include the patient voice within this big consortium. So you can see 7 questions which has been sent all over the world, not only Europe and USA, but patient association in Japan, in Australia, in Asia as well, India. We did have a very, very short time to display this survey and let people answer it, but we were really happy to see the number of response we've got. So exactly the same survey was sent to clinicians and patients, which is important. So you can see here the 2 first questions and the main one about the name, the eponyme Sjögren. So here you will find a couple of comments that we received. For the first question, typical comments highlighted that there is finally a recognition of the term Sjögren, the name Sjögrens, and change it now would hurt our visibility as patients. About Sjögren, we do have some difficulties for this unknown disease, so if now we change the name again, it could be very harmful for us. And for the second question, patients were more divided, so do you agree with changing the term disease? The majority of comments for shortening to Sjögren included those wanted to keep the S, frequently highlighted that the S makes the word easier to say. And quite a few also suggested using Sjögrens with no apostrophe. But overall, though, there was a slight preference for Sjögren without the apostrophe. So the big question, syndrome or disease, again and again. But it was important to capture really the thought of patients. And as you can clearly see, the vast majority of patients wanted the term syndrome discarded, and we obviously prefer the term disease. Again, a few comments that we received. We received, Cathy and I, more than 1,000 comments on the term syndrome, with patients obviously seeing it, this term as negative. The word used most frequently by patients in their comments was serious. That disease connotes the seriousness of Sjögren and legitimate the disease. Syndrome was more described as being dismissive, sorry, minimizing, vague, making Sjögren seen as not a real disease. Again, patient's word, but more as emotional issues with symptoms clearly sometimes imagined by the patient. So disease is recognized better that Sjögren can be, again in patient words, crippling, debilitating, and life-altering. It better demonstrates the impact Sjögren has on patient, and as such is more respectful of the burden a patient carries every day. So patient burdens of the disease, and it confers dignity to patients. The beautiful primary and secondary Sjögren was also included in the survey sent to HCPs and patients. So no surprise, patients very much disagree with the term primary and secondary. Their vote registered more than neutral on the term associated. Again, comment extract from the answer. We received over 1,000 comments and responses about the term primary and secondary. And patients were emphatic that we discard definitely those terms. we talked a bit yesterday about it, but most patients interpret or find that others interpret, which is important as well, primary and secondary as defining the severity of the disease and describing the impact of the disease. Patients said that secondary labels Sjögren as a second-class status, less important and less severe, which is right. So now the term associated, that comments from patients. The votes on use of associated were, again, much more neutral. Some stated that associated was at least better than secondary if we need to keep something. But many patients thought that the word associated carried similar negative connotations as secondary, and question the use and ask really the use and the necessity of any qualifying terms. So, does any qualifying term is necessary today? We all know that a patient with rheumatoid arthritis and lupus, we won't say, nobody will say rheumatoid arthritis associated to lupus. No, clinicians will say this person has a rheumatoid arthritis and a lupus. Why don't we do the same with Sjögren? Why can't we do the same with Sjögren? She has lupus and Sjögren. She has, or he has, lupus and sclerodermia. Why associated? Why this name? We don't know, and that is not our choice. The patients were really, really happy to have the possibility to express their views, and including patients in Japan and Asian and South Africa, because they don't have any federation to be aware of that kind of initiative. So they express their gratitude for being included in a decision that will have major repercussions for patients. And in addition, many patients express themselves appreciation for the work the nomenclature initiative is doing, and for what language changes will mean to them over the long haul in facing a disease that many others perceive as less important and less burdensome than other relative diseases. I think that's the major point. Patients feel that the name of the disease impacts their management. So finally, to conclude, a consensus was reached, a definite one was reached to Sjögren or Sjögren's disease. A manuscript will be published soon by the consortium. Many international patient association, organization, or federation have already dropped syndrome. Was really, really happy to drop syndrome. Many of them have already dropped primary, secondary, but as I said, no consensus for now. No consensus for primary, and within the nomenclature initiative, there is a majority opinion to recommend not using primary in a clinical practice in individual patient care, but to keep it and to assess it, to assess its use in scientific publication to homogenize the population order study, exactly following the same argument that arise regarding the use of the classification criteria. So in summary, the language we use has a tremendous impact on the way everyone views the disease itself and the patients who have this and manage this disease. Patients overwhelmingly feel that the terms syndrome, primary, secondary, make them feel less than and less validated. If the nomenclature initiative succeeds in dropping all these terms, I really think that we patients, associations involved in that nomenclature, we will change the face of Sjögren's disease. And we, patients, we need it. Thank you.
Thank you very much, Coralie.
No,
was very clear. That's the patient's voice. Thank you. Next speaker about the unmet needs from the perspective of clinicians is Lucas Chatsis. I'd like to give you the word again. Please.
It's Lucas Hadjis. That's difficult, but
Sorry, Lucas.
yeah, perfect. So good morning. Yesterday, before your lovely dinner under the Acropole, under the Mediterranean moon, we had the chance to talk about a new promising project called Necessity, entrusted with the mission of addressing some of the clinical unmet needs of the disease. Today, we are going to go much deeper and talk about all the clinical unmet needs of the disease, all the challenges we face as clinicians, taking care of patients with Sjögren's. And trust me when I tell you that there is no shortage of clinical unmet needs for Sjögren's. But before we begin, just let me talk very briefly about some special characteristics of the disease. Sjögren's disease is the most female predominant autoimmune systemic disease. Yesterday, Valerie told us that Sjögren's is a borderline rare disease. Is that correct? That's good. It develops perimenopausally. It is usually slowly progressive, but always difficult to treat. And it can be found either alone or together with any other systemic autoimmune disease. We used to talk about primary and secondary Sjögren's syndrome. These terms are considered obsolete for many reasons. One of them is that it makes no difference regarding therapy. And the clinical spectrum of the disease varies, and we should keep that in mind. We have non-specific manifestations, such as Raynaud, arthralgia, arthritis, depression, fibromyalgia, and many others. We have periepithelial manifestations, with the cardinal manifestations that we all know of a dry mouth and a dry eyes. But other glandular surfaces can also be affected, and we have symptoms of dry skin or xerotrachea, dry cough. But extraglandular epithelia can also be affected. The epithelium of the lung causing interstitial lung disease, or the kidney causing interstitial renal disease. And then we can have the systemic form of the disease, the most aggressive form of the disease, an extraepithelial immune complex mediated disease with the immune complexes having cryoprecipitatable properties. This form of the disease causes glomerulonephritis, palpable purpura, and peripheral neuropathy. Last but not least, we have the most serious complications of Sjögren. It is lymphoma, mostly of the mild type, but we might also have other more aggressive forms of the disease, like DLBCL lymphoma. And this is important because patients with Sjögren's disease develop lymphoma more than 2 times than patients with lupus, more than 4 times than patients with rheumatoid arthritis, and almost 19 times more than the general populations. And here you can see the latest 2016 ACR-EULAR classification criteria. For the first time, we have an entry criterion. The patient should have at least 1 symptom of oral or ocular dryness, or score a point in the ESS-DI score. And then you can see the classification criteria, 2 major items, one representing the autoimmune process at the glandular level with a focus score equal or above 1, and the other one representing the autoimmune process at the serum level with positive Sjögren's syndrome specific anti-Rho autoantibody. And we have 3 minor items mirroring the objective measurements of dryness either in the mouth or eyes. A patient is classified as having Sjögren if he has a score of equal or above 4. That's all. Let's now talk about the clinical unmet needs. And if we want to talk about them all, we need a lot of time, not only 10 to 15 minutes. So we will try to see and organize them. From my perspective, the clinical unmet needs of the disease begin way before the disease is diagnosed. and follow the path of the disease, the trajectory of the patient in each and every step of the way. And you will understand my way of thinking. During pre-diagnosis, during diagnosis, and during follow-up, and with an overarching principle regarding treatment, we need to do things to improve our patient's life. So, let's begin with a pre-diagnosis. As you all know, the symptoms of Sjögren's begin way before a formal diagnosis is made. And there is a multitude of reasons for that, but in my opinion, the most important reason is the fact that many caregivers, many medical specialties, do not know all the intricacies of the disease. Dermatologists, ophthalmologists, ENT doctor, internists, the first responders when it comes to Sjögren syndrome patients are not well educated about the disease, and they do not promptly refer the patients to the expertise center. And this results in a delay from the symptom onset to disease diagnosis that this may span from 5 to 10 years or even longer. And if we want to go even deeper, we now know that patients have Sjögren syndrome specific autoantibodies even before, many years before the first symptoms appear. And this is a period that in an optimal way we can act and make the disease never appear. So what should we do? First of all, we should raise awareness about the disease. We should raise awareness about the disease among the general public and among different medical specialties in order to reduce the time from symptom onset to symptom diagnosis as much as possible, because this results in a lower degree of damage accrual, and maybe therapies can be more effective if we give them earlier in our patients. To do that, we should understand better the pathophysiology of the disease. Now we know the orchestrators of the disease. We know that the epithelial cells play an important role, B cells forming germinal centers with the help of T cells and T follicular helper cells, but we do not know everything. We do not understand how the immune process gets deregulated. Let's jump on the diagnosis part. We know that, judging from the classification criteria I mentioned earlier, a lip biopsy is not necessary for the classification of the disease. A patient can have positive anti-Rho autoantibodies and an objective measurement either in the eye or mouth, and he can be considered a patient with Sjögren's disease. But in our department, and from what I heard in Portugal as well from Vasco, and I believe in all departments, expert departments across Europe, almost all of our patients undergo this small interventional procedure that I believe, but you know better, that it is not pleasant. So why do we do it? Because we, the doctors, are in desperate need to find that number, the focus score, the histopathological signature of the disease, mirroring, reflecting the inflammatory process around the epithelial at the glandular level. The focus score is determined by the number of mononuclear cell infiltrate containing more than 50 inflammatory cells per 4 square millimeters. It can take any value between 0 and 12, and the positive biopsy is considered the biopsy that has a focus score equal or above 1. So why do we need it? We are in desperate need of the focus score because except for the diagnostic value that it is known from the diagnostic criteria, it has also a prognostic value. The higher the focus score, the more extraglandular manifestation the patient is going to develop. And that is, we know that mainly from works from Italy, from Karoubi and others. But also, doing a biopsy gives us a diagnostic and prognostic value regarding lymphoma. And it can also guide our patients' follow-up. That small proportion of patients that have a focus score above 4, they are in great danger of developing lymphoma, and these patients may be rebiopsied a few years later to achieve an earlier lymphoma diagnosis and a better prognosis. So there are a lot of things to do in this field. We should discover novel blood or saliva biomarkers that share the same properties, diagnostic, prognostic, help us in the follow-up of our patients. And I know CXCL13 has been considered one such biomarker, but there have been conflicting reports. Up until that optimal time, we will continue to biopsy our patients. That is not very good, but we should expand the information we get from the biopsy we already do. It's not just the number of foci. It's not that just the number of it's not just the focus score. What about the number of cells? What about the number of cells in each foci? What about the T and B cell relationship? There are many things to find in early biopsy. And we, among others, use artificial intelligence, and with others, use artificial intelligence to try to untangle all this hidden information in the minor salivary gland biopsy. And this is what we know about the follow-up of our patients. There is no optimal re-examination plan of when, how, when to do an ultrasound, when to see the patient. Professor Giufas yesterday gave a very elegant presentation of the Harmonics project. And it is true that it gave us some information based on information we, the doctors, know practically by heart for our patients. The age, the gender, information about the autoimmune profile. And now we can allocate our patients in a good phenotype, patients that have no autoantibodies, triple and quadruple seronegative patients, the patients that who have a great danger, they are in risk of developing lymphoma, male patients, patients with a higher focus score, young patients. But what Professor Giufas did not tell you yesterday is that in real-world settings, things are not like that. It is probably more like this. What happens if we have a patient who is male, who has a focus score of 2, and is also seronegative? Is he a patient that should be followed up very closely, diligently, or not? So we do not know. That is the answer. We need to find biomarkers that monitor disease progression, that help us stratify patients into smaller clusters, and also biomarkers that give us a very good response to treatment. We talked about that extensively yesterday. We should also find the optimal follow-up plan, not for all Sjögren syndrome patients, but the patient we have in front of us. And we also must identify the best predictors of lymphoma. We've heard about many, many predictors of lymphoma. We should find the best model of lymphomagenesis, and we are working on that. And now, let's talk about the Achilles tendon of Sjögren's, the treatments. I will not say much because you know it, and the table says it all. So many studies from 2004, more than 15 RCTs using different agents, anti-TNF, interleukin-1, 6, CD20 depletion, many abatacept, many trials that share a common element. They have all failed. They do not meet their primary endpoint. There is some glimpse of hope. I said that yesterday as well. We have some trials in the last few years that have some potential. Some of them they don't have a lot of number of patients, like the hydroxychloroquine and leflunomide. Now Necessity will answer this question. Ianalumab, anti-BAFF, anti-CD40 treatments, BTK inhibitors with some promising results. We will see. What do we need? This is a heavy slide. We need disease-modifying drugs that can slow or halt the progression of the disease, as we do in other autoimmune diseases. But that's not all. There is room for improvement when it comes to symptomatic alleviation. We need to find long-lasting treatments for dryness in the eyes and mouth, and we should also deal with accompanied symptoms like peripheral neuropathy, fatigue, fibromyalgia. But I prefer to say that we need to improve the quality of life of our patients, and we do not, we fail miserably doing so. And I don't know if I have any time. I just want to say, to wrap up with this very important slide. You know, precision medicine has been in the center of global attention, both medical and beyond, in the last few years. And we should not forget that the fundamentals applied were laid more than 2,000 years ago by this guy, Hippocrates. You can see the statue. It's 5 minutes from here. It's from my university. You can go. Who said that it is far more important to know what person the disease has than what disease the person has. And I think this simple but very astute sentence should be our guide when we try to tackle, when we try to solve all the previous unmet needs of the disease. So this says it all. Thank you.
Thank you very much. Also here there are questions. And now Gorley again about the unmet needs from the perspective of
Hi, it's
patients.
me again, but I'm here on behalf of my friend and colleague Anna Vieira, who couldn't attend for health reasons. So we are thinking of her, and I try to deliver a message. So thank you, Lucas, for the clinician perspective. Obviously, we share a lot of things in common, but not all. Well, it's a bit... I hesitated before this slide yesterday when I've done it, but concretely, from the patient perspective, we don't have any satisfying need in Sjögren yet. We know you're trying a lot, and we know you understand, but no. For now, it's no. Unmet need today for us, it's not satisfied or not fulfilled need. So the work of patients' association and patients' advocate or represent our partners is to really fight to make understand this statement. We are all patients representative here, patients advocate, patient partners in clinical trial. We need to keep that in mind and remind it everywhere. Serious, systemic, disabling, complex, and heterogeneous. One of our major unmet needs and a big issue for patients is not having a disease properly recognized. Obviously, you clinicians, pharmas, and fellow patients, we all know that it's not CCAS syndrome, but 80% of patients are still fighting against this idea of Zika. Sjögren is dry disease. No, Sjögren is a very systemic disease. And I like very much this Sjögren Foundation picture that I always use when I speak about our disease, with all the systemic issues patients can encounter, and of course, no approved treatment, even if we thank you all for the hope and the results you deliver during those 2 days. So we still hope, but today, for all of us, no approved systemic approved treatment. Is here, I shouldn't say that, but I love that publications from Professor Vasco Romao, Sarah Talarico, and colleagues from ERN, because that shows at international level in 2018 already, that shows the commitment and the involvement for patients and their will to address and work on those numerous unmet needs. We all know, and it has been said already, I won't be long, but unmet needs today impact quality of life. All aspects of our life are affected by the disease. Obviously, the love life, because we often forget our relatives and the couple life, the family, the kids, the sleep, the brain, and any outdoor activities can be affected. The first one will be fatigue and cognitive dysfunction, thanks to Alessia Aluno yesterday, who really start a huge work on neurological issues, because it's a major complaint for patients. And 88% of patients, according to the Sjögren Foundation survey, 88% of patients are reporting debilitating fatigue. 88, it's huge. It means that patients can't do daily activities, 88% of them. The causes of the fatigue and the neurological issues are still unknown, as the rest of the disease, of course. But these are the biggest challenge for patients. The second one, of course, is pain. Massive complaint again. And even if some types of pain are treatable, it remains an unmet need, as it is a huge burden every day and clearly affects deeply the quality of life. And it's important, again, to differentiate pain, because there's not only one pain. As I've written here, it's physical pain, but it can be emotional, neurological, of course, inflammatory, and we don't know where does the pain come from. The emotional and psychological impact, I choose this picture, and I think it means a lot, because this impact for us patients is huge, often underestimated and under-considered. This burden, the invisible character of the burden, the lack of understanding, the stress of living with it, and the depression that can occur, the difficulties and so on, this leads for all of us to sadness, loneliness, and depression. But again, what is important in that is that we are not depressed. We feel depressed because we do have that disease. And it's often the other way around. A lot of patients are coming to their GP by saying they're sad, they're depressed, go psychologist. And that's a huge unmet need for all the medical community to understand that if we feel like that, it's because of the disease and not the other way around. So today, the most answer to that particular state of mind is go to see a psychologist, which is not the answer. We know, and we heard yesterday about mental health, but if we are like that, it's because of that, and not the other way around. We are not ill because we are depressed. We are depressed because we are ill. And that's something we need to take care and be strong about it. The interrelations between those three major symptoms is a vicious circle that we are experiencing really daily, and which makes life difficult and highly decrease our quality of life. It's obviously really easy to understand that symptoms are difficult to cope with every day, and often patients don't have help, they don't have education, they don't have access to multidisciplinary clinics, because there's a lot in some countries, but in big cities, and the vast majority of patients can't have access to that specific consultation or reference center, and no interdisciplinary work between specialists. So the patient needs to run from one specialist to one another, and it's complicated, and again, it's a burden and a daily job and daily work. Apart the quality of life, we do have unmet needs on quality of care. Too few patients benefit today in any countries from comprehensive and multidisciplinary care. So as I said earlier, the difficulties to find and talk with a GP or other specialist who knows and understands Sjögren is real. The lack of the disease and the self-management program is dramatic. Delays to diagnostic and treatment, lack of knowledge, again, understanding the disease. All those are really affecting the quality of care for patients. So what can we do? Basically, what can we do? We still have a lot to raise awareness about Sjögren. And we, as patient association, as patient advocates, we do have a huge role to play. We need absolutely to educate our patients. A patient who is educated will better manage the disease, will better manage his life. We can collaborate exactly as we are doing today. We can collaborate with scientific society, we can collaborate with hospital, with rheumatology unit, with neurology, cardiology, whatever. We can and we need to promote research. I talked yesterday, and I know that in clinical research, they can't involve patients, they can't find patients to include, because patients are not aware of clinical research, clinical studies, because patients don't know how a clinical trial works. And the answer when we offer to patients to be included is, I don't want to be a guinea pig. We do have a lot to do to educate patients, to teach them what is a clinical trial, what is a clinical study, what is research, to foster patients' involvement. And finally, the partnership. We need to be patient partner in research as well. Again, to remind again and again how difficult life is with this disease. And to conclude, the main sentence, and it is our sentence in Sjögren Europe, together we are stronger. Thank you.
Thank you, Coralie. That was a clear message. We like to open the discussion now with all of you. If there are any comments, reactions, questions, we start with Vera.
Hello, I'm a PRP and a patient advocate in the RN Reconnect, but I'm also a psychologist, and I would like to add a small comment to what Coralie has just said. One of the answers to help the unmet needs, it's a multidisciplinary approach, and we should choose psychologists in the branch of health psychology. That's what I do with oncology and palliative care. We don't work with depression, we work with people, with persons with a chronic disease. So maybe our diseases, like mine and Sjögren, needs the good branch of psychology that is adapted to this kind of patients. When they come to me, I always say, I'm not going to treat your mental health. It's not about that. I'm going to help you, your journey and your path and your unmet needs, working with strategies to achieve a better quality of life. So that's really important, and I really see a less or few psychologists talking in this kind of conference and workshops and wherever. So Linda was the only one, but we need more and more and more, because there are studies about coping with chronic diseases, and we don't address the mental issues like depression and anxiety. We address pain and fatigue. That's the two main unmet needs that we address. So we should go to a health psychologist, and we should work in the unit of rheumatology, like I work in the unit of oncology or palliative care, and be a multidisciplinary approach, and that will be helpful, and I see great results.
Thank you, Vera. This is a very important issue, and I think it's very hard in the world that there are so few psychologists that know about this. So we have quite a lot to do on that topic, I think. Thank you.
Yeah, thank you, Vera. The thing is that we do have a long road to get that state of mind within our hospital and our clinics. And again, if you speak to patients, most of them are hiding that kind of difficulties because they think that the clinician will put all the symptoms on behalf of their depression. And they think that the GPs, the rheumatologists, the whatever, will minimize the impact of the disease and maximize the impact of mental health. So we do have a lot of work to do to explain to our patients and to communicate with you clinicians to make them confident to speak about their difficulties. Again, as I said, it's not because we are depressed that we are ill, but most of patients often say, no, I haven't told that I cry every night because I don't want to be judged and I don't want to be sent to a psychologist. So we do have a lot to do. And if I may comment, we talked about it yesterday, but one way to address those unmet needs from clinician to patient is exactly the way we are doing now, being gathered in a room with us patients, you clinicians, you pharma who are supporting both clinician and patient. That will be the way to address our unmet needs.
Linda, please.
Thank you. Yeah, just to follow up on what has been said, and I couldn't agree more with Vera that there's medical psychologists and health psychologists who are focused and targeted on these issues who could help. But I think there's two pathways, or at least two pathways, in which the Sjögren's Europe can help also educate the doctors and other healthcare professionals. One is empower patients to speak about their mental health and their struggles with mental health and quality of life. And the other pathway is to educate doctors and other healthcare professionals through e-learnings, through partnering with professional societies, and educate them about the needs of the persons in front of them as well, and give them some tools to help them as well while they're in their offices, because medical doctors are not necessarily trained in mental health and well-being, and they may not have the tools and may not know what to do when the person actually expresses their concerns with mental health. So those are two pathways, at least, that I think Sjögren Europe could help address this issue, or at least make a start with that.
Thank you.
Thank you. Just to join on this discussion, and precisely on this matter of the psychologist and mental health. I mean, don't get me wrong. I'm pretty sure that most physicians, this is a very severe handicap that we have in terms of how can we deal with this. We struggle to deal with our own health, so let alone patients' mental health. So. But at the same time, I think, and I've felt this, that sometimes when you do try and when you want to help, and there's even the possibility to do that, because most of the time this is not even a possibility, unfortunately, that this may be seen by patients as us trying to disregard the complaints or saying it's not important. I'd say it's the opposite, to be honest. I wouldn't expect someone that is, feeling tired and in pain and cannot do the normal activities to have a normal mental health. I mean, it's just, I would say that would not be expected. So when we talk about comprehensive care and really analyzing what are PROs, what do they mean, and so on, I think this is something that we need to look at. And by definition, doctors are not equipped to do like a whole psychotherapeutic process. So I think there's so much to do here, but I'm not sure. I mean, I can see what Coralie is saying, that sometimes this is just, dismissed as, okay, this is fibromyalgia. This has nothing to do with this. But of course, this is a defensive behavior by physicians that don't know what to do. They want to help, but they can't. And I think we've all felt that. But at the same time, I think that is starting to change in a few settings, especially in more specialized centers. And this is for Sjögren, but I think all rheumatology. And really, I think this should be seen as a good thing. I think at this point it doesn't really matter if you have a disease for 10 or 15 years, if it's what started first, Sjögren's or the depression or the anxiety. It's just part of the whole same thing. It's not more or less important. But if you want to feel better, and I think that's the goal of patients and doctors, I think you really need to address it all. Yeah.
Thank you.
I think, yeah, so first of all, I thank you for all the suggestion. I think it is really an important point. I mean, I was just interested in your thoughts. Sorry, I forgot your name. I'll look it up. Yeah, so we know that health psychology is in such short supply, and I do think that I also agree with Coralie. There is an image problem. I think when we touch on that, I think people need to normalize the need for the support of health psychology. That's different from saying somebody who got a mental health problem. So I think, I don't know how you can normalize.
Can you talk in the microphone?
Sorry.
Yes.
So I tell you something that we are doing in our service. I don't know whether that could be a intermediate step. So we have a wonderful occupational therapist who have some training in health psychology. So the way that I approach, we'd have some successes, but don't get me wrong. I'm not saying here, I solved the problem, the huge problem that we couldn't solve. So we would approach it by mentioning about we need some help with the pain and the fatigue at the moment. Until we find some amazing new drug, we still need to deal with it. And I know that our occupational therapists have some training in health psychology, and she deliver an amazing program. So I think, and also I think the other thing that I struggle with in the clinical practice is, I think for our, well, I shouldn't say patient really, for our people who are living with a condition, I think they need to come to their own journey to be ready as well. I certainly make mistake in my life and, thinking, oh, I'm sure this person could do with some help. But actually, I don't think if they're in that right stage of mind or right stage of life, approaching it is actually often have a very opposite effect. And so it's very difficult. I find the whole thing, there isn't, we like to have a protocol, guidelines and everything just step by step. But I find in this particular area that there really isn't any. And I think the other thing that I'm just going to say about the multidisciplinary service, I mean, for those of you who know about the UK, we are really in a very challenging time. I'm struggling. I'm day by day asked by my manager, why are you seeing so few patients? But if you got 5 minutes in your clinic, you cannot do anything really. And to actually add in other, not as expensive as doctor, but other professional into the clinic, that model would never be accepted by the current NHS, which is really sad, really. So I do think that we probably need to think of a different model. Could we deliver this kind of care in a different setting? I mean, I like to see the NHS could improve, but I see that it's in a really slippery slope now, to be honest. I don't know where else we could go. But anyway, so sorry, I'm mumbling on. I'll pass it on to someone else.
Yeah. Yes, sir, and please.
Thank you. So I think there's some very interesting discussion here on psychology and bringing things into the clinic, and having worked with a lot in the person-centered healthcare, person-centered communication, collaborative care, and finding models for operationalizing this. I think there could be some interesting discussion of how that could be applied in Sjögren's. So the work that I've been involved with in many other diseases is when you come to that it's about effectively collaborating with the healthcare team. So ensuring that the people, the patients, as well as the health professionals, have the tools that bring them together in an effective sharing and collaboration that is focused on helping the patient express what is most important for me, what are the challenges, express and educate the health professional about my reality, and what is important for me to be treated. Because you have many different challenges, and you need to prioritize together. So there are very, and then the health professionals needs to understand how to be respectful, how to be listening, how to understand the nuances, how to engage in that nuanced discussion, and you can collaborate. So we have developed a lot of tools in diabetes and other conditions that have actually proven to be really successful in bringing together that construct. So instead of going to the clinic and say, okay, let's look at your blood sample and let's look at your symptom and then let's make a treatment plan. No, let's look at what your reality looks like. What is it that fills in your life? Is it the pain? Is it this? Is it this? And then you already come prepared. And the health professional understands and respects that whatever you say is part of what we're going to deal with. But I also have my agenda as a health professional. I want to take care of your physical health and make sure everything is covered. But that's the collaborative person-centered care model. And that is quite evidence-based today in many disease areas. And maybe it's worth considering working towards clinical care guidelines, that Sjögren's condition requires that personalized, and I know everybody agrees on that, but you can further put it into guidelines and operationalize and say, this is what an encounter needs to be about when it's Sjögren's. And we will not have multidisciplinary advanced care for everybody right then, but you can always focus on the individual encounter has to have that respect, has to have that holistic approach and collaborative approach.
Thank you.
Good morning, everybody. All of this reminds me one word, empowerment of the patients. So if we have empowered patients, then they can collaborate with their physicians, they can collaborate with their psychologist, they can accept that they have the need to go to a psychologist, because especially in southern countries of Europe, we have a stigma about psychologists and psychiatrists. Okay, all people, they have, most of the elderly people above 60 years old, they have the perception that if they are going to a psychologist or if they are going to a psychiatrist, they are crazy. So there are a lot things that we can do as patient organizations, and of course, of the other way that you, the scientifics, you can do a lot of things to improve the perception, and you can also collaborate with us, the patient organizations, to change this mind of the people. And if we empower patients, then we will have better results and better life of the patients.
Yes.
Thank you.
Thank you. And the last one, because we are running out of time. Thank you.
Thank you. I wanted to speak about another subject than fatigue and depression, if it's possible. I just want to thank the patient for the work they made concerning the name of the disease, because for me and for, I think, all my colleagues working on Sjögren, they consider they are treated patient with a disease. And for me, I didn't care, sorry, Coralie, about the name. It was not a problem for me. I didn't realize it could be. And it is really with the patient link and the work of Cathy Amit or some Alan Barron, I don't know, who helped you to do that. That's we changed the name, and I think it's good because I realized that for healthcare or administration or something like that, it was important to have not syndrome but disease. So, good job.
Thank you.